Hello. Yeah.
Good afternoon, everyone. I welcome all of you to this gathering of Science Club Colloquium. I would like to request Professor Kumbhar, the coordinator of Science Club Colloquium, to welcome the gathering.
Thank you, and it's a great pleasure for me to welcome all of you for this Science Colloquium activity that we have been doing over the years. This is the third colloquium in this semester. The first one was by Professor P. Balram on chemical communications in biology, and second one was by Professor Uday Maitra, also from IISc Bangalore, on soft materials from bile acids, and he also demonstrated a few experiments. And today is the third in this series this semester, and we are very fortunate to have Dr. Rajendra Badwe, the director, Tata Memorial Center, Mumbai, who's going to talk to us on cancer, need for crosstalk. And this is actually a gathering which is best suited for a crosstalk, which will include science and also some other activities that Professor Badwe is going to talk to us. I thank you all for coming. Let's have a very nice lecture. The students have been given a piece of paper, an A4 size of paper, where they have to write a technical summary of the lecture, which they have to submit to me by 5 o'clock today. Two best summaries will get a prize during the next Science Colloquium, which will be in July 2018. Thank you for coming. Let's have a nice talk, and welcome you all once again. Thank you.
Thank you, sir. I would now like to request Professor Gadre to please felicitate our today's speaker, Dr. Badwe. Since Science Club Colloquium is an activity that is run by the students, we would like to request Akash Sargam, a student of health science, to give a small and brief introduction about Dr. Badwe.
Thank you, Radhika. It's my privilege to introduce Dr. Rajendra Badwe on behalf of Center for Complementary and Integrative Health and Science Colloquium, Savitribai Phule, Pune University. It's quite difficult to actually compile his introduction in a brief, but we have tried our best, sir. Dr. Badwe, currently director of Tata Memorial Center, has more than 26 years of diverse experience as a surgeon and as an oncologist. And presently, he is leading Tata Memorial Center, a world-renowned institution in the field of cancer. He is an international opinion leader in oncology, developing breast cancer care strategies, innovative research, integrating delivery systems, improving quality and cancer care programs, and capacity building of staff on cancer care delivery strategy and practice issues. His significant accomplishments in leadership in cancer care are a testimony to his role as a mentor in developing the cancer care strategy for Government of India and World Health Organization. His pioneering work on timing of surgery for breast cancer has induced a paradigm shift towards importance of events at the time of surgery. He is a frequent traveler and speaker in number of national and international programs and meetings and conferences, and has more than 100 publications in several journals to his credit. He is a recipient of prestigious national awards and honors and gold medals. He is serving as a member and coordinator of WHO Guideline Committee and member of UICC TANM Committee, and he's also serving as a reviewer for many important and journals, including Lancet. Thank you.
Thank you, Akash. Without any further delay, we would like to invite today's speaker, Dr. Badwe, on stage and deliver his talk. This is the slide changer and this is the pointer on the slide.
Thank you. Dr. Gadre, Dr. Kumbhar, and friends. It's indeed a pleasure to be here. And as I was talking to Dr. Gadre earlier, the need for crosstalk. We are in a learning mechanism, or the methods with which we impart education these days is, if there is a huge amount of wealth of information, data, then we break it into smaller and smaller bits. And the purpose, everybody very strongly says that the purpose of breaking data into smaller and smaller bits is the best way of understanding it. I reinterpret that by saying that we are unable to understand the data when it is big. So it is for our frailties, our convenience, that we break it into bits and pieces which are then understandable to us. But finally, having understood that bit, we forget which was the bigger component. So while looking at a big forest, difficult to fathom, difficult to understand, and what we tend to do is concentrate, get into a smaller and smaller bit and understand only one tree, and then assume that this tree is your world. Now, this kind of smaller and smaller bits is what has happened today, that there are individuals who are doing biochemistry, there are individuals who are doing some other kind of structural chemistry, there are some individuals doing some different kind of physics, quantum physics, nuclear physics, and then different kind of physics has sub-branches within it. And we have forgotten that in nature, there are no such divisions. All this is in a symphony, excellent togetherness, which creates a bigger design. And that's the reason why I have decided to talk on crosstalk. We, in fact, for our own understanding, divide our own subject into smaller and smaller bits so that we understand. But finally, we have forgotten that what was the primary purpose, what was the original reason why we broke it down for understanding this bit, but all put together, it should make a bigger sense. That's the reason why we are into what we are doing today. So cancer has also gone through the same kind of activity. And while we understand cancer, we have forgotten that there is physics that we use, there is chemistry that we use, there is a biochemistry and biophysics that we use in that. And finally, all that affects our system, our own bodies. Let's look at some numbers first. I am very fond of numbers, and there will be lots of numbers in my talk. So, cancer in India versus cancer globally. How different are we? And lots of things can be learned out of that too. So here are some numbers. If you look at US or UK, the numbers are every year, for every 1 lakh population, there are about 300 cancer patients. This could vary from 280, 290 to 350 in some parts, but around 300 is a number that they have. In urban India, this number is 100. So we are 1/3. We are much better off. In semi-urban India, say if I were to look at Pune, Miraj, and any of the mid-sized towns, Pune is no more a mid-sized town, it's a metropolitan city today. So you have already inched towards 100 per 100,000. But otherwise, it would have been somewhere close to, what have I done? Okay. So we would have been somewhere close to, Pune would be somewhere close to 100 by now, whereas smaller mid-sized towns will be between 60 and 75, and rural India is between 40 and 50. You might say that there are lots of missed cases. There are lots of cases that are happening in rural India. We may not be detecting them, and since we are not picking it up, that's why your numbers are small. But that's not the case. There are about 4 or 5 registries, rural cancer registries across India, and we do a house-to-house survey on annual basis, covering more than 1 million population, and the numbers have been constant. They are between 40 and 50, and they have remained static for quite some time. To the extent that breast cancer in this population is so low that it's somewhere close to 8 or 9, and this is the only population where the number has remained static at 8 and 9. So Bill Melinda Gates Foundation put in somewhere to the tune of about more than $1.5 million in a town close from here called Barshi to understand why breast cancer is so low in that region, and can they export something to United States so that their breast cancer incidence reduces, because in United States the numbers are close to 120 per 100,000, whereas in Barshi it has remained 8 to 9 per 100,000 population. We do have a pocket in India, northeastern India, where the numbers are high in some pockets, and we are quite close to the western population, and we are studying why that is happening. But you must have noted that about 20 years ago, the number of people who spoke about cancer versus today, the number is quite high today. And we perceive that cancer is much bigger today. And that perception is not actually correct, because this number of 100 in metropolitan has remained 100 for the last 15 years. The number which is 60 to 75 in semi-urban has remained that for last 20-25 years. And the rural numbers have also remained static for 20-25 years. So we are not rising. But what happens is, read the last sentence. Every decade in census, we get to know that some bit of rural population has become semi-urban, and a lot of semi-urban has become urban. So there is a transition of individuals from this population to that population, and that population to that population. So the absolute numbers would rise over a period of time, and our population is also rising. We are not stopping our reproductive abilities at all. So which gives us that there would be a lot more people in India, and that also will give us more numbers. In general, I will try and allude as to where all you, maybe student of physics, engineering, students of chemistry and biology, could give inputs on that. So we already have about a third of what US or UK has in our cities. Now, what are the kinds of cancers? If you look at a great majority, all these three put together constitute about 70% of our cancer. So 70% of our cancers are preventable. Now, prevention, very easily possible. We take care of tobacco. Tobacco accounts for about 40% of cancers in India. So tobacco accounts for about 40% of cancers in India, and infections account for another about 15% of cancers. But as we get into urbanization, wherein running water is available, human hygiene has improved quite a bit, that itself reduces many cancers. And one of the best example is cervical cancer in women. That has gone down remarkably. In Barshi, it continues to be about 30 per 100,000. In Pune, it has come to about 12 per 100,000. And in Mumbai, for quite some time, it has come to 8 per 100,000. Now, this 8 compared to United States, where it is 7.5. So we are no different as far as personal hygiene is concerned in parts of India. But in rural India, where men take bath on a common well, putting on their clothes still on while having bath, the personal hygiene is going to be poor. And the possibility of these infections being transmitted to women are pretty high. So uterine cervical cancer continues to be high in rural Indian pockets. Another big scourge is obesity, which is a urban phenomenon. Increasing weight. A great number of if you go to schools today, almost all children are pretty roly-poly. You know, and yet majority of the women, mothers, if you talk to, and I do go to many schools to talk about cancer awareness, and I find that all children are very, very paunchy and big ones. At the end of the talk, when I talk to parents, there is not a single mother who doesn't say that the child doesn't eat. And I wonder, if child doesn't eat, where does the fat come from? But anyway, there is some reason to believe that we need to take care of obesity, which is an urban phenomenon, and obesity accounts for 13 different kinds of cancers. So 13 different cancers will reduce remarkably if we don't put on weight. So I'm sure there are people who are here, maybe from, I don't know whether there are any from engineering background, but one could think of what kind of solutions one could think of that if you are working in a workplace, and while working, if you have a chair that has a small bicycle. So you are working, but you are working your legs continuously. I found this very nice chair on Zurich airport, and the coffee shop had all the chairs that had a bicycle at the bottom. So if you are having a cup of coffee, obviously that should be without sugar, you would continue to do some exercises. So while you are doing something, could you exercise yourself? Another area which one could easily work on is the travelators that we keep on getting at the airport. Now, the travelators allow people to walk if they want to. If they don't want to walk, they will stand, yet will go at the other end. But a travelator that is moving at, say, 5 kilometers an hour is a speed at which we walk on the footpath. One could easily step onto it and start walking on it. If we walk on that travelator, which is moving at a 5 kilometer per hour, you will walk at 10 kilometers an hour. Because you are walking at 5 kilometers, the travelator is moving at 5 kilometers, you will walk at 10 kilometers. So let there be two travelators, one by the side of the other, and the other travelator moving at 10 kilometers an hour. You step onto that, you start walking on it. You are walking at 15 kilometers an hour. I don't think in Pune, in peak hours, one can drive at that speed. It is an impossibility. For a kilometer, you would take about 25 minutes during peak hours. So if in business district, if we have this kind of travelators, or even long distance, I keep on giving this example of from one end, say Warsaw in Mumbai versus Gateway of India, the distance through sea, wherein there is a sea link that is happening, one part is already happened, or the coastal road is that is happening, the distance would be about 14 kilometers. Imagine I start walking from Warsaw, and in an hour's time, I would be at Gateway of India. Today, sitting in a bus or in a train, the travel time is about an hour 45 minutes, sitting at one place. In an hour, I would not produce any kind of pollution, and breathing a fresh sea wind continuously. Imagine if the whole Pune is to walk, or whole of Mumbai was to walk from one end to the other to go to work. While we are doing this activity, I'm sure we would be a lot healthier, and I won't have the reason to practice medicine at all if cancer reduces remarkably. And reducing obesity is not only going to reduce cancer, but it is also going to reduce diabetes and high blood pressure. So stroke as well as heart attacks, all of them will reduce remarkably if we were to tackle obesity to some extent. So some kind of a solution, either doing exercise or creating a machine that will allow you to exercise while you are doing something else. Because it's damn difficult. If you ask somebody, are you willing to go and exercise in a gym? Some of them will, but those are individuals who are already thin. They are not the ones who need exercise. So if you ask somebody else, all of them are extremely busy. So busy that they can't find time to do exercises. We then get on to, from there on, the logic is that if I were to treat small cancers, the cure rates are close to 80%. 80% of them will survive and will have a normal lifespan. The same patient, if it were to be detected with cancer, when the size is much larger, and I would say, for example, call it T4, the cure rate will be 20%. So why can't I have all of them diagnosed at T1? And then all of them will have great survival. We would conquer cancer without any problems. Now, that's a very simple logic, should work. Unfortunately, in biological systems, you need to run experiment to actually see that it works. And what has happened, that it has succeeded greatly for oral cancer, that you pick up somebody who is chewing tobacco, examine his mouth once a year. That individual himself can examine, or herself can examine, and look for any ulcers, white patch, red patch, and seek medical advice if there is something. And that kind of activity itself reduces the death rate related to oral cancer. We have proved it beyond doubt. Uterine cervical cancer with pap smear or visual inspection, again, cure rates are easily possible to a great extent. Breast cancer, when the similar trials were done, great amount of reduction in tumor size by doing screening, but reduction in deaths only in women above 50. Women below 50, there was no reduction in death. So when it comes to biological systems, there is something else that is functional, and we don't know how to do it. So is there some other way? There are many other places where things have failed miserably. Look at prostate cancer. There is an excellent biomarker in blood called PSA, prostate specific antigen. Now, if we were to pick it up, a great number of prostate cancers will be picked up when they are T1 size, small size prostate cancers. The same thing was done, but at the end of 15 years of follow-up, we find that there is no difference in death, whether it was done or not done. In fact, the death rate was higher when it was done with PSA estimation. So it might appear logical, but it doesn't always come true, or our biomarkers are failing. So we need to look at the same failure we have met in lung cancer and breast cancer below 50 years of age, that there is in fact an excess death. You do an investigation, pick up early tumor, and more people die of that cancer. So no part of the world offers screening for these cancers, except when you have yourself found a method of estimating PSA. Then you want to sell something. That's a completely mercantile reason for you to sell something. It doesn't matter whether somebody lives or doesn't live. That's not the purpose, but there is a huge amount of overdiagnosis. That means there is a difference between somebody coming to me with a symptom or with some problem versus me going to all the population. I just now mentioned that if only 100 people get out of 100,000, that means a great number don't have cancer. In fact, the majority don't have cancer. We are looking at approximately 99,999 individuals, 980 individuals who will not have breast cancer, any cancer at all. But if I were to screen, suddenly the cancer starts rising. And a lot of cancer that has risen in United States and UK is because of their act of observation. More they look for, more cancers will they get in return. And that doesn't necessarily mean that the lives are saved, because the number of people dying of cancer in that country are higher compared to what our country has. So this problem of overdiagnosis there, well, where have we failed then? We need to understand where have we failed. There are lots of people who today talk of liquid biopsy. There are lots of labs here in Pune with the kind of bioinformatics background that is available in Pune. There are lots of labs that offer that we'll do a blood test and we can pick up an abnormal cancer cell. Now, the problem there with liquid biopsy is this is a technology. Again, somebody from your end who is doing biophysics will understand that the precision with which I can now look at a cell that is circulating has improved remarkably compared to what it was possible 10 years ago because of the technology. Now, technology is available, I can look for cells. I look for cell, I get some cells. Where has it come from? Do I know where the cancer is? No, I don't know. So I run a test, then I ask for a CT scan. Whole body CT scan I do, or whole body MRI I do. And if I don't find, then what do I say? You don't have cancer at the moment. but you will get someday. So these tests have slowly become a bit of astrology. We need some solid evidence to say that there is something coming up. What I'm trying to tell you is that there should be something that is tested robustly, gives an evidence which clearly says that lives are saved by performing the test, and then such tests should be offered to everybody. So this is what the president of ASCO is one of the major societies globally in United States, but globally functional, that there may be multitudes of things, that I may have a circulating tumor cell or circulating DNA. The rate at which technology is getting into precision, that we get huge amount of data. I ask one question and I get so much of data that finally I need to understand the question that I asked, has it been answered, or something is thrown back at me with 100 more questions rather than answering one question that I have asked for. So we need to take this with a pinch of salt, that there may be technology, but that's only information. Technology is giving information. Unless you ask a proper question and confirm that the answer is what you expect, or otherwise, then you can either uphold that technology or dump it. But we need to be very clear in mind as to, is that possible or not. But presently, whatever biopsies we performed or imaging that we performed can't be replaced by any of these newer technologies. So technology is there, but we need to sip it properly to understand as to whether this is useful at all. Now in general, again, the same gentleman talking about, if you have a test which is bad, then it is worse. It is worse than giving a drug, because you are then looking at a healthy individual being stamped with cancer or stamped with a possibility of cancer and leave him in society for years to come. That's not the reason why we are here. We are here to reduce disease, not to create disease in society. So what are our failures? I want to detect killer cancer cells. I want to detect a killer cancer. I don't want to detect cancers which may be there lurking in tissues. Lots of cells change their patterns, change their phenotype to appear that they are cancerous, but they don't have all the phenotypes of cancer to kill the host. It's quite similar to Vurtezor. You know, these small felonies that are performed, we are not looking at small felonies. We are looking at somebody who will pick up an AK-47 and fire 100 people down, kill 100 people down. That is what we are looking for. But while looking for AK-47, we get so many other small thieves that the number of cancers start rising. And that is a problem. So I would urge those who are doing their biophysics, biochemistry, look for a marker that will pick up killer cancer, not all cancers. To give an example, if 1,000 women walking on the streets of Pune without any diagnosis of cancer, if they were to be examined by a trained female health worker or a trained gynecologist for their clinical examination of breast, I am looking at women between 35 and 75 years of age. In such 1,000 women, a clinical breast examination might pick up one cancer, which was not diagnosed earlier. The same 1,000 women undergoing a mammography will increase this number from 1 to 2. I then use MRI, more precision technology. That number 2 will become 4. God forbid nothing should happen to these women, but if I were to look at women dying of vehicular accident between the same age group, 35 to 75, and if I were to perform autopsy studies, post-mortem studies to understand whether the breast has cancer or not, and to my surprise, I find that in such 1,000 women, there are at least about 200 cancers. So how much are we picking? We are picking only 1, 2, 4, upper limit 6. We are missing out on those rest of 194. which are lurking in population, but they will never surface. That means our human body has capability, even if some cells turn abnormal, they are not allowed to manifest themselves to threaten the host. Now we should not allow our bodily defenses not to be functional like this. If we keep on picking up these cancers, we will get cancers, and those cancers will be treated. And then finally, if I were to treat only cancers that are lurking in the population without ever manifested, all those women will live for next 20 years. Saying that hey, I have conquered cancer, but in the first place, that cancer would have never manifested. You understand what it is? That unnecessary procedures can give rise to unnecessary diagnosis, unnecessary stamp. And that unnecessary stamp will allow any of the doctors to become extremely popular. That you go to this doctor and you never die. No, that's what I'm selling. I'm selling immortality. As a doctor, I don't want patients to die. So the purpose of my presence is to sell immortality. So that's what I'm doing at the moment. But my failure is that I cannot give more than 20% cure rate for somebody who is presented to me late. Instead of me saying that I have that failure, I tell that patient, you have come late. You understand? That I have transferred my guilt onto that patient, saying that it's not my fault, you have come late, that's why I can't cure you. But primarily it is my problem. And we need to find solutions to that. Let's look at some of the solutions. And let's look at some of the older solutions. There are some graphs here. These are survival graphs. That means, say, for example, the top graph shows those who have taken a medicine. The lower graph shows those who have not taken medicine in low risk population. The top graph, high risk population who has taken medicine, and high risk population who have not taken medicine. So between taking medicine or not taking medicine, approximately 5 to 12% reduction in deaths. So 5 to 12% reduction. This is using either chemotherapy or stopping ovaries. Whatever that is, that's not important to understand. But simple therapies, these therapies would cost somewhere to the tune of about 300 to 500 rupees. Ovarian ablation will not cost anything at all. It's a small surgery which takes, it's a daycare surgery. Similarly, another medicine called tamoxifen, a tablet, a packet of 10 tablets cost about 15 rupees. And you need to take one tablet a day. Now, if taken for 5 years, the end result is that there is a reduction in death from 45% to 33% by taking the medicine. That cheaper medicine giving you a difference which is 10%, 12%, 15% reduction in death. Let's go to these are the results of yesteryears. About 30 years, 25 years ago, these trials were done and huge amount of benefit by least side effects and least damage to the pocket. Look at what happens now. Today, we have chemotherapies or we have some other different agents being utilized, taxanes and other things. The cost is about 30,000 to 100,000 rupees. The cost of medicine here is 30,000 to 250,000 rupees. For that kind of cost, what is the reduction in lives? The reduction in death? The reduction in death is 2%, 2.5%. What has changed over a period of time is for bag full of money, you have that kind of differences. We need to look at it that can we utilize some chemical moieties that any of you are working on. You have a thought process. It could be serendipity. It could be a focused area that you're looking for. When I say serendipity, I'm looking at, say for example, how does metastasis set in? Metastasis is a process by which cell leaves the primary tumor bearing area, goes somewhere else and settles there and starts replicating. That is a distant metastasis. And cancer can kill only when it metastasizes. So it is the metastatic disease that kills a patient, but that movement of cell is what is important. Now, can there be some drug that any of you are working on which will increase the adhesion between cells? Is that a possibility at all? When I say serendipity, I'm looking at a pathologist looking at cervical smears in women. Scraping from the uterine cervix is looked upon under the microscope to find out whether there are any cancer cells, what we call pap smears. A pap test is done for diagnosis of cervical cancer. Now, if you look at that, then if you ask a pathologist that suddenly a pathologist from Guy's Hospital came up with a thing that there are some percentage of women wherein repeated test doesn't give any cells at all. The procedure is done appropriately once, repeated twice, repeated 3 times, but the cells just don't come. What does that mean? That the cell-to-cell adhesion is so strong that even your spatula, as it crosses against, as it abrades against the uterine cervix, no cell can be exfoliated from the surface. And what was found, that a great majority of these women were heroin addicts. So we are looking at cannabis. Cannabis induces huge amount of cell-to-cell adhesion. Cell-to-cell adhesion is so strong in cannabis I'm not asking you to take cannabis, please don't misunderstand. I'm just giving you an example as to what can serendipitously come onto your labs and then investigations further to understand. So we are investigating, is there a possibility of utilizing this part of it without the addicting part of it, without the psychedelic part of that drug being so appealing. So there are so many things that can happen. Another drug which is hugely expensive, giving rise to a very teeny-weeny benefit. Look at, from your distance you can't even see that the graphs are separating out there. But graphs are separating. They're separating for 1.5%. 1.5% benefit for a single tablet to be taken for 5 years, and the cost of the tablet is approximately 350 rupees. 350 rupees every day for 5 years, that's huge amount of cost. Not many people will be able to afford it. The same thing true is for Herceptin. This takes the cake. The cost of this medicine, which gives you a difference of about 5%, is approximately 20 lakhs. I can't afford it. I don't think great majority of us will ever afford it. So we need to understand as to how best we can find out drugs, either repurposing drugs, existing drugs being taught a new trick, or getting a new drug which is simple enough without much of cost involved. So who benefits from treatment? If I go back to the graph, you will find that even if I don't take medicine, that many will live. Even if I take medicine, that many will die. And only that many patients will have a difference. Is there some way of me knowing who will be benefited like this? Then I will give only to these 5%. But today I am giving to all 100% of patients. So the only person that is benefited is the industry. We are not helping the patients at all. So we need to understand who benefits. Is there any way of finding out who benefits? And there are ways. There are tests that have come up, and any of your biophysics individual or biochemical individuals could work on what's there on the surface for me to understand, will this drug be useful at all? Say for example, using tamoxifen and finding out whether they are estrogen receptor positive. Since I'm giving an anti-estrogen treatment, it will be beneficial only if there is an estrogen receptor on that cell. If there is no receptor, the cell is probably using survival pathways which are distinct compared to estrogenic pathways. So such simple things can be utilized, and we can still get some better scores out of this. But in general, there are various things which may be useful, and today we are in the world of genomics. So we know hundreds of targets. I keep on doing a genomic analysis or analysis which looks at the expression of DNA, that is mRNA expression. So either RNA-seq or a DNA analysis to understand what is targetable in that tumor. So we run a study. This is the in thing today, and every industry is doing it. So a study was run wherein all the targets, I look at the biopsy sample, look at all the targets and hit these targets with drugs. These drugs are phenomenally expensive. But I hit only that versus giving the general medicine without knowing whether the targets are there or not. So a general chemotherapy which is today termed as a blunderbuss approach. So, with a great aplomb, we looked at this study that something will come out of it. Unfortunately, having gone through all that, we find that finally one out of 423 patients that signed on it, only 194 had targetable genes available. And more importantly, finally having gone through all that, only 48 patients had genomic driven treatment. And how many had objective response? 9%. 91% did not have even objective response, leave alone eradicating disease, leave alone cure. That is far away. So we may have a fantastically good thought process, but we need finally to get into clinic to understand whether something is useful at all, or it's only a great logic that there is a receptor and I need to treat the receptor with some treatment. Similarly, there are molecular targets which are refractory, the very famous SHIVA trial. Again, a negative study, targeted tumors. What I'm trying to drive home here is that there may be lots of patients finally being treated, a very small percentage gets treated, and the benefit out of it is close to zero. But there is a logic. There was a logic, and today a lot of patients still take treatment exactly based on this because it is appealing. My tumor is unique, and that uniqueness of my tumor I'm going to hit with some bullet that goes straight onto that tumor. Is there a possibility that I can do it? No, and the benefit is extremely small, and there is just no way. See, so many targets were found, so many targets were hit, and in spite of doing all this, we find that that's the survival figure. Whether giving or not giving, red or blue, there is hardly anything to choose. So there may be logic, but finally in a biological system we need to prove whether that logic is upheld or not upheld at all. And we have no way to say that there is any benefit at all. In today's world, personalized medicine is the key word. Everybody wants to use personalized medicine, being a little precious that I have something unique and that unique is being hit is something that everybody wants to try, but it doesn't give us exactly the same thing. And why does this happen? Every time a tumor cell divides, it produces new targets. So if there are 100 cells there, all are not dividing at the same time. 10 are dividing today, 10 are dividing tomorrow, and another 20 might be dividing 10 days down the line. Every division produces new targets. So even if I have a target that is expressed only in 10% of the patients or 10% of the cells, those 10% of the cells might die. But that doesn't mean the other cells will continue to be there. They will replace, they will repopulate all that dead tumor within no time, and with every division of repopulation, new targets will come up. So it's a smart cell that is beating us before we even think. So tumor heterogeneity is something that is killing us at this juncture in practicing what is termed as personalized medicine. So the conclusion of that was that there was a technology that gives huge amount of information, but is it useful in the clinic? So however, the simple view of directing therapy on the basis of genetic tumor markers is probably too simple and has failed miserably. The only way I can say that this was said a long time ago, that physician's belief in his treatment and the patient's faith in his physician exerts a mutually reinforcing effect, and the result is a powerful remedy which is almost guaranteed to produce an improvement and sometimes a cure. But that's a placebo effect as described. So one might have benefit out of it, but presently we are unable to cure. There is no way I can ever say that the failure that we have ever say that recurrent disease has been cured. Recurrent disease remains incurable in any part of the world, and Sushruta in his writings had written that recurrent disease then was also not curable. So what has changed? Sushruta's time and now, something that is there once record cannot be cured in any way. We need to understand how can we reduce our cure rates, reduce our recurrence rates so that we can improve our cure rates. Stage match survival has also not improved remarkably. I'm actually giving you a very pessimistic view of what's happening in the clinic, but that's the reality. Screening is successful in few cancers, but in great majority it has failed. We need to find newer solutions. I'll give you one or two examples quickly, and then we can get on to some question answers. I just now mentioned that 10% of the tumors might be expressing, tumor cells might be expressing some targets. The targeted molecule goes to that cell, gets attached to that cell, but has the capability of killing only 10% of those cells that are expressing. Those cells are also 10% in the tumor. Is there any way I can do something? Can I go to our quantum physics people? Get me a radio-isotope. Here is a bullet that targetedly goes to the tumor. Can I increase the payload on top of this molecule? And if I can increase the payload, then the molecule which has the capability of going to tumor will carry this payload there and will blast off the whole of the surrounding area. So if one cell was to die, 10% of the cells were there expressing. These 10% of the cells will take up the molecule completely, and in the surrounding vicinity of each cell, there will be a killing which will affect more than 2 to 3 centimeters of tumor. So is there any way that we can create such smart bombs? There are two areas where we are functioning at the moment with the help of physicists from BARC, the Bhabha Atomic Research Center, and we have used lutetium and few other yttrium, iodine-131, any of these to be tagged onto a molecule, and the end result is that what we could be achieving by giving 9 months of treatment could be achieved by giving only one injection. So reducing the duration of treatment, reducing the cost of treatment. No industry is going to do it. We need to do it. We need to convince our government that please give. Your cost of medicine is going to reduce by 1/9. Instead of 9 months of treatment once every month, the patient will take only single treatment and will have the same cure rates as 9 months of treatment. Similarly, there are many other targeted agents which we are looking at, but essentially, we are looking at somebody from physics allowing us to create a smart bomb which will not interfere with the ability of this molecule to meet the receptor which is there on the tumor, and also release the isotope which it is carrying on its back. So both those activities need to be done, and a lot of input from young minds like yourself would be of great use. Those who are doing chemistry, if they are into medicinal chemistry, I need to find a molecule which will stop invasion of the cell. A cell that has come in, killing or digesting the surrounding tissue so that it can invade into surrounding tissue, which is the biggest property of invasive cancer. Or cell-to-cell adhesion. I mentioned about cannabis. There is another drug, naturally occurring hormone called progesterone, that also increases cell-to-cell adhesion to a great extent. So there are ways and means of finding out what can work from chemistry side. Here are some pictures that are of tagged molecule. This is Herceptin, a drug that is used against HER2 positive. HER2 is a tumor expressing growth factor receptor that when positive the cell grows much faster, and if that is positive there is a targeted molecule called Herceptin. And I showed you the figure earlier that this molecule goes straight to the tumor, but its ability to kill is not very great. It kills, but it doesn't kill all the tumor cells. So the difference in survival is somewhere to the tune of about 5% to 8%. That is the kind of difference. But the cost of this drug is 20 lakhs of rupees. And we need to use it for 1 full year. Imagine if we were to have targeted, so we have tagged this molecule with lutetium, and it reaches liver, which was studded with a tumor, and over a period of time, the same molecule completely eradicates the same tumor which is there in liver. People who are doing physics could help us in 2-3 things. Here is a machine, an old machine, but machine made in such a way that if there is no electricity, it can work on UPS. It can work on a UPS and deliver radiation to the cancer patients. If I were to give radiation 5 days in a week versus 6 days in a week, my cure rate improves by 10%. Imagine if I have a machine which works only on electricity and half the time the machine is not working in a rural component of India, then how do I deliver 6 days a week treatment? If I were to give only 4 days treatment, instead of improving 10%, I'm going to have a detriment of 10%. So we need to look at what is required in our own country. If electricity is not available across, for some rural pockets, we need a machine that will work on UPS. So this is a machine produced by physicists in Bark, and that works on UPS. It will work on electricity also, but if there is no electricity, it will work on UPS for 24 hours. So it is easily possible to treat patients without any problems. That's the kind of UPS on which it works, and it will sustain itself in spite of no electricity. Last time when we had the visitors from the IAEA, International Atomic Energy Agency, they have picked up our machine, and there are at least about 10 such machines that have gone to various parts of Africa and some of the parts of Orient. Vietnam has, Sri Lanka has, Bangladesh has, and there are at least 8 other countries in Africa that have our machine. That Mongolia has, thank you so much for that. Mongolia has the same machine, and these are countries wherein there are no radiotherapy machines. So this is the first machine that is functional there. This is a low-end machine. Can we think of a high-end machine and seek some inputs from physics people? Let's have a look at that. This machine is giving gamma rays. A linear accelerator gives me either photons or electrons, accelerated ones that have the capability of penetration. Penetration, and such penetrated particle deposits energy in the tumor bearing area and then escapes out. So it's a very sharp kind of knife that goes, kills bit of tumor but also goes outside, and while going out it can create another tumor in long run. So if I have a 90% cure rate, such 90 individuals, if they are living for 25 years, they might get another cancer in the region where I have given radiotherapy. So we are now looking at a newer technology. Can I have a slightly heavier particle? I accelerate that particle, and that accelerated particle goes to the tumor and deposits itself in the tumor. So there is no exit beam. So if there is no exit beam, there is no residual radiotherapy that goes to the normal, healthy surrounding tissue. And if that doesn't happen, then I have lesser cancers, greater long-term cure rates. If I can say that 80% are cured today, 20 years down the line, 80% will remain cured if a second cancer doesn't evolve in the exit beam arena. So there is a machine that comes with protons. Now here I need a thought process from your end. Protons are hydrogen. It's plain simple hydrogen that is accelerated. There are now thoughts that a slightly heavier atom, carbon, if I were to accelerate that can have a greater killer ability. I need to understand that will need much greater energy. A 250 MeV is the energy required for proton, whereas carbon will require 450 MeV. And 450 MeV would mean huge amount of circular area where the acceleration. So the circle that produces carbon is approximately 90 feet wide. Imagine a dome that is 90 feet wide made of solid steel, that it will not allow this accelerated atom to escape, because if it escapes, it will kill anybody. So look at how these have evolved. Europe and USA have concentrated on hydrogen. So there are companies that manufacture protons. Japan, and there is one more company in China, they have mastered the technique of carbon. So they are selling carbon. They say that carbon is more effective. Probably carbon is effective in some deeper parts. Hydrogen is effective only in superficial parts. So do I buy a hydrogen producing machine as well as a carbon producing machine? The cost of hydrogen producing machine is 250 crores. Whereas that of carbon producing machine is 850 crores. Imagine what is when the cost of the machine that you saw just now, this cost of this machine is 2 crores. How many machines will come out of that? A 250 crore, 850. And if I then were to buy an 850 crore worth machine as well as 250 crore worth machine, the whole spending of the country for health will go only in 2 machines. That's not the way we should be functioning. But where is the solution then? Is there a solution? Can we think of a versatile machine which can, with a switch, change 2 things? What is the source atom that is coming out? Can there be a tray wherein I replace the tray, the first tray has hydrogen. I want hydrogen now for the next 20 patients. And I will accelerate hydrogen. So the energy required is 250 MeV. I use only 250 MeV. So I need variable energy. I need a variable source and a conducting system that will go to the patient and hit the tumor properly. So is there a possibility that I can have a single machine, not 850 crore of one machine and 250 crore of second machine? Can we have a single machine? I would love to have inputs from physics people that can I just change a tray and switch the amount of energy that is served to this accelerator, a synchrotron. Is it possible that I can use only these 2 changes and produce at will either carbon or hydrogen? This kind of a thing will happen only if some of you start thinking in these lines and put your head into it. It's 20 years of hard work. Then there is possibility that we will have something. So there are lots of areas. I just gave you a few examples of what can be useful or what can't be useful. And majority of the things that we learn out of nature's design. So I keep on showing this slide, and this slide used to be not exactly the same slide, but multiple colored flowers being shown. That one of the Nobel laureates, Richard Feynman, would describe this, that there used to be, as a kid, father taking them into garden, and there will be lots of kids who would come. There were some fathers who would talk about the color of the flower or how many petals are there and so on and so forth. There are some fathers who were biologists. They would name the flower. So naming something, and then that child would give some horrible name which you never heard of. So rather than calling this simple Sadafuli, there will be some Vinka Tinka Chunka or some weird name coming out of it. But more importantly, what Feynman writes is that look at these flowers. That there are flowers of various colors. The purpose of those colors is to attract insects. Unless the insects come there can't be cross-pollination and reproduction or a continuation of the species. What does that mean? The conclusion is that the dog in your house doesn't have color vision. We all know that. But insects definitely have color vision. Nature will not create a flawed design wherein it creates 100 colored flowers and the insects don't have color vision. So look at it, that let there be a conclusion drawn out of nature's design, and you will have lots of solutions that come out of for treatment of cancers. Thank you very much. I want to believe that there is something in Ayurveda. Why do you think it has not come out? Why do you think we still rely on Herceptin, spending 20 lakhs for a 5% benefit, but we are not willing to look at Gugul? We are not willing to look. Why is it so? Why is our walk of medicine, the kind of medicine that we practice, is on the roads today, and the Western medicine is in the palace of hospitals? Why is that? And the reason is very simple. that they have opened themselves to inquiry. That if I am talking about a drug, say Herceptin, then I want to know 100 people given with hypertension, Herceptin given versus another 100 not given. And if this is successful, then I know. So they have opened themselves to inquiry, which Ayurveda refuses to do it. We have tested 2 such drugs, Ayurvedic drugs. Everything in animal experiment and in petri dish appeared extremely promising, but in biological system, in human body, completely unsuccessful. And I keep on telling our Ayurvedic individuals that you tell me which is the best medicine that you have in the best of the indications that you have. I will get you 100 patients like that indication and you give that medicine. But you need to tell me when should I look for the response, and I will look for response. Don't even tell me whether you are giving drug or not. I will just document a response, so let there be an independent inquiry into what you are doing. If I say I am right and I keep on giving medicine, I will always be right. Isn't it? Somebody else should say that I am right. I shouldn't be saying that I am right because I am doing something. We need to open ourselves for inquiry, and I am sure there will be something in Ayurveda. So if there is somebody at your end who is willing to run trials, ask the patient. What kind of patient wherein you have the best foot forward, the best medicine that you have? Let's look at a good randomized study and prove it once and for all. If that is proven, I'll give you another example, arsenic. Arsenic in Ayurvedic, in Bhasma, arsenic Bhasma, that is most effective medicine for leukemias. Most effective. Today it is a standard of care. Why is it standard of care? Tested in randomized trials. But unless we do that, opening oneself to inquiry is the most important thing. If I were to say that all swans are white, then I should first stand up, go around the world to look for a black swan. Rather than somebody giving me 20 black swans. You are wrong. That's not the way it goes.
I have a question for first few of your slides.
Yes.
You mentioned that in some of the cancers, early screening or screening is not helping reducing the death, but rather you see excess death, like PSA and stuff. Why do you think that happens?
I have been working on it for the last 25 years. It will be probably a 2-day meeting for me to explain to you what exactly happens. But I'll give you a simple example. If there is a electron that is moving around the nucleus, I don't know where it is. The moment I try and find out where it is, the position, for finding out that position, I have disturbed that it will have 0 velocity at that juncture. For that juncture, I will know where it is. So the act of observation changes the observed. You understood what I'm trying to say? Now imagine that there are 50,000 men and another 50,000 men wherein I have done PSA testing. There are 50,000 men here who have not been tested for PSA. The number has been taken randomly. So in any randomization, the primary assumption is that there are equal number of cancers on both sides, right? On one side, I am able to pick up, by screening, I pick up approximately 180 cancers. More than that, sorry, about 200 cancers. Wherein I don't do PSA, I pick up only 100 cancers. Now there are 100 cancers deficit. What's my assumption? That these 100 cancers are lurking in the other population. They will grow. And in the next 10 years, they will manifest. I wait for 10 years. What happens is, in these 10 years, only 20 of them come up. 80 don't come up at all. So 80 are silent. They are silently sitting in that population. There is a huge amount of overdiagnosis here. Now imagine that I may have 80% survival in individuals detecting early. So out of 200, 40 will die. On the other side, I have not 80%, but prostate is not a very greatly killer cancer. So not many people die, even if it is late diagnosis, but people die. Now, if there, the survival is 70%. So out of 100 diagnosed, only 30 die. So out of this 50,000, 30 have died. Out of these 50,000, 40 have died. So there are 10 more who have died because of screening. So it is by sheer number. And by diagnosis of those numbers, if the others don't come at all, there is no question of dying. The conclusion is that act of observation decides who is to disseminate, who is to not. So there is a huge body of research that is happening today on that line. Yes, please.
What's the role of nanotechnology or nanoimaging?
Nano is, in fact, a technology by which access can be gained. Suppose I have these vertical rods that you see there in the door. If I have a 8-inch molecule, and if I go straight like that, it will not go through those bars. Now I turn that into an 8-inch molecule in one dimension, and the other dimension is micro. It will just walk through that. So that's all it happens with nanotechnology. That one dimension of your molecule is of a nano caliber. Now if that is the case, the possibility of having access inside is good. That's all. It doesn't increase killer ability. Yeah.
So we agree that the metastasis is the primary cause of case, right?
Yes.
So therefore the CTCs or the CTC DNAs are actually telltale signature of metastasis. We also agree that, right?
No, I don't agree with that.
Okay. So
The reason is there may be cells, but are they viable to create metastasis? There may be cells in see, I'll give you an example. There was a very elegant study done of injecting cells into circulation, in mouse circulation, in 2 cardiac beats. 1, 2, twice heartbeats. There was no cell left in circulation. So the cell, because of the eddy currents, a great majority die. Even if I have in patients circulating cells measured, and there are patients with circulating cells, without circulating cells, the difference of survival between the 2 such patients is something like 25%. But that means a great majority with circulation also don't die. So there may be cells in circulation, but do they have the capability of creating metastasis?
So my question is there that if targeting these cells when they are in a peripheral blood and killing them, will that be a prevention to a metastasis for this low number of cells?
I would say that we have plenty of medicines that can either kill a cell or produce some changes in cell which will abrogate the cell's ability to metastasize. It's possible.
They are in an active circulation.
Once they are in circulation, it's useless. The access is already there. Can we prevent access to circulation? That will prevent metastasis. Killing metastasis has failed miserably. We're just not able to kill metastasis. Yeah.
So you have come across thousands of cancer patients, and actually whole world is looking at the early markers of cancer. But are there any non-invasive markers we can detect cancer at earlier stages or even before they are diagnosed?
There are plenty of markers like that. Unfortunately, they are not useful in clinic. Either they don't have the specificity as to where the cell has originated from. And the second important thing is that I gave you an example of physical examination, mammography, MRI, increasing the precision. So finally in a system, we have to find out whether it saves lives or not. So I do physical examination in 50,000 women. And in another 50,000 women, I do physical examination and mammography. Increasing precision. How much is the addition of mammography in saving lives. I am asking a question that I am able to palpate in one group of individuals, all tumors. In the other group, I am treating palpable as well as some impalpable picked up by mammography. So is it worth improving that precision? Is it worth treating impalpable tumors? This randomized study has had a 25 years of follow-up, no difference in death. And about 30% excess cancers treated in mammography group. So precision doesn't necessarily mean that I am picking up killer cancer. That's why my failure, I said, I am unable to pick up with a good biomarker a killer cancer. I pick up all and sundry. Some of them can kill, some of them can't. Yeah.
In your opinion, immunotherapy against cancer, do you think it would have a significant role to play in the management of cancer?
There is a huge amount that has happened today. In melanoma, there has been a big change in treatment and outcomes with immunotherapy, that cancer cells do not allow the surface of that cancer cell is exactly like a normal cell. So the abnormal surface proteins are covered. They are not exposed to the cells that decide self versus non-self. And the non-self also grows. There are now methods by which it can happen that will kill these cells. And melanoma has been a great example. Lung cancer has been another example. Some of the renal cancers and bladder cancers have also have been amenable to this kind of treatment. But cell kill. In melanoma, there is a survival difference. In others, we are waiting for that survival difference to come up. The problem is different. If these molecules have the capability of picking up some of the non-self which appear like self, will they do that for some normal cells? And that also is coming up now. A lot of them produce interstitial lung disease. They produce thyroid problems, that thyroid gets destroyed by these kind of molecules. So there is a flip side to everything. But yes, immunology is very much high up in the focus today.
So my question is that is it like that the early diagnosis, so the statistics says that the early diagnosis of the cancer is equal to more mortality. So is it because of the exposure of these chemotherapy agents that is a contributing factor to the death?
There is no chemotherapy used in prostate cancer. So not true. In breast cancer, in early breast cancer, there is no chemotherapy used. Some of the late breast cancers, yes, chemotherapy is used. So chemotherapy is not there in every tumor, no.
So what's the cause behind the high incidence seen in Northeast? Is it because of the high consumption of red meat?
Tobacco. Red meat consumption is also one of them, but not very great. Red meat consumption and the fruit and vegetable consumption is something which is very high in the rest of India. So if you look at colorectal cancer put together in India clocks at about 8 or 9 per 100,000 per year. The same number in United States is 75 per 100,000. So we are healthy. Anything from the West is not the best.
That means the diet can control the...
Sure, it has already been controlled. We don't need to control that diet, but we don't need to adopt the Western diet.
So with vegetables and some fruits, if we increase the quantity...
Absolutely. It should. There is evidence that increasing roughage in the diet reduces cancer. There is direct correlation. Yes. No direct evidence.
We are actually encouraging the intake of fruits and vegetables, but what about pesticides these days?
Wash your fruits and wash your vegetables well.
Is it really sufficient? Because these things are bombarded with the pesticides.
Yeah.
We see grapes.
True.
They are not removed. So again there is the dilemma whether we should consume them in big amounts or not.
Well, I guess there are people who are producing it without insecticides and they have their own market. They have to say that those who are using insecticides are bad. Otherwise, how will their product sell? I must say that insecticides are estrogenic, and excess estrogen does produce this kind of a problem.
Sir, you said that the cells which can cause cancer are developing constantly in our body.
Yes?
So if I compare two people, one whose breast has been removed surgically, who has received chemotherapy and radiation, and now I compare it to a normal person who may have that marker for that particular breast cancer, and now if I compare the possibility of learning cells with those markers, so what are these probabilities? Are the probabilities same for finding the markers in the person who has received the chemotherapy?
The sensitivity of these markers, when I say sensitivity, in what percentage we'll pick up something, that sensitivity is very poor. That means if the sensitivity of circulating tumor cells is somewhere close to 40%, that means 60% of the cancers are missed. They will not be diagnosed. And there will be another 10-20% who will be falsely positive. So, useless test. Completely useless at the moment.
Sir, how do you decide a particular patient will require chemotherapy and not?
Sensitivity. We have a sensitivity analysis to understand whether this is useful or not. Let's have others asking questions. Yeah, the gentleman in specs.
So the last slide in which you showed stars and then you started off with this, that we should be inspired by how nature works.
Right.
So I have a question related to that. If we consider rats, which live for around 3 or 4 years when kept in a laboratory, where we take good care of them, but as compared to rats living in the wild, which have to face many other opposing forces like predation, lack of food, nutrients, everything. So let us say they are living for a year lesser. So they are living for 2 years.
That's an assumption. Do you know that?
But
Okay, let's assume. Okay.
so now I read somewhere that laboratory animals, rats, wild type rats, right, which were kept in the lab, they started developing cancer as their lifespan was increasing. But now, if you look at wild rats, they will not show cancer. The first reason is we won't go and see if they're having cancer or not because we don't bother about them. Second reason is before they could develop cancer in the late stages of their life, they're dying before that. Now, if we compare huge animals with us, like whales or hippopotamus or even elephants, so these are having large masses as compared to us. They are having a lot of cell load, which means they have to divide the cells and make a big mass for their body. But they live longer than us. For example, turtles or even tortoises which live for 300 years, but they don't develop cancer that well. So can we have they obviously have certain defense mechanisms against cancer which are better than us. So can we have something from them and include this?
You have touched upon too many things in one go. It's not easy to answer any of those questions, but I will just give one suggestion. If you were to ask a turtle, how precious does that turtle feel himself or herself? And ask a human being, how precious that person feels. That feeling that I am precious is what produces insecurity within. And if there is an insecurity within, it will manifest with some form of corrective measure. If you feel that you are inadequate, you want to improve. Even the cell thinks the same way. You keep on hammering your cell that you are inadequate, you are inadequate. Finally, a bit of that will start changing its own DNA. And the purpose is to feel that I am inadequate, I need to be better. I need to be different. Better is a thought in mind, in reality it becomes different, and that difference is not sustainable. What is cancer doing? Cancer is a live organism that is trying to live within a host, and in the process it kills the host. Right? It actually kills the same host that is supporting it. And the cancer will also die in that. but it has no capability. It doesn't have the organization capability to sustain the whole body. It doesn't have that within it because it has changed its DNA code. Our body functions damn well because the liver cell never feels that it is more precious than lung cell, nor does it feel that it is more precious than brain cell. All of them are Gunya Govindan and Antai.
I have. See, you alluded to something like what we call uncertainty principle.
Absolutely.
You were mentioning that is Heisenberg gave that in a microscopic world. Now, what you are saying is there is some evidence in macroscopic world also an act of observation disturbing the system. Is it tested or is it? It's a very interesting phenomenon.
So, the example that I gave you just now of 50,000 individuals and 50,000 that there is excess death happening if you start diagnosing cancer. If you leave it undiagnosed, it doesn't kill. Now, does that mean that the act of observation is actually changing the observed?
Not in this case.
Now let's look at what's happening to the tumor. So we did an experiment which has just gone for publication and is for presentation. Hopefully it will go, we'll have some good slot in the forthcoming ASCO. That when the patient is under anesthesia, I'm talking about, I do breast cancer surgery, so I picked up samples from breast cancer. The tumor, before I start surgery, I do a core biopsy, 4 or 5 core biopsies. That means the tumor has normal nutrition, normal environment, microenvironment is same, oxygenation is same, everything is excellent. I do core biopsy and I do expression profile. What genes have been expressed? mRNA expression. I then, while performing surgery, I denude 50% of the spherical area of the tumor. That means there is some bit of hypoxia, some bit of nutritional reduction has happened. I do again 4 core biopsies. And then, finally, in 15 minutes time, the whole tumor is in my hand. Completely anoxic, without any nutrition. I do core biopsies again. Between the first and the second, there is a difference in expression profile of more than 1,200 genes. 1,200 genes either light up or go down in a span of 8 minutes. It takes me 8 minutes to go around on one surface of the tumor. And by the time it goes to the last one, that 1,200 gene difference has reduced to 20 genes. So the difference between the first and the last is hardly any. I find the tumor is still there. Now imagine, I love to extend that to a normal simile. I walk into an alley wherein there are about some hooligans. My first response is I want to fight. I will have all the strength in me. I will have everything possible that I want to do or I can do. I will bring it in myself. Somewhere down the line, if I find that I'm losing, I will withdraw that. I want to run away. It's plain simple fight and flight response, which is there for any organism. And the cells are also exactly doing the same thing. But it is happening in a span of 15 minutes. So look at the sentiency of our DNA mechanism. 1,200 genes going up and down within a span of 8 minutes and then again coming back to normal in another 8 minutes.
Some kind of biological uncertainty. Something of that.
And also, we have now looked at these 1,200 genes. A great number of them are actually metastatic potential genes. Genes that bestow metastatic potential on cells. So obviously there is something happening by act of observation, even at molecular level.
Is there consistency in this differential expression pattern?
Yes. In 30% of them, it consistently happens. 30%. We have about 24 triplets. 24 first sample, 24 second sample in the same patient, and 24 third samples. One last question. You reconcile who's going to ask and finish one question. Yes, yes. There is an anti-angiogenic agent that can reduce angiogenesis to close to zero, but no life saved. But no life saved. It has been a big failure. Avastin is the name of the drug. Complete failure. Not used for anything. Maybe one or two indications here and there. I didn't show the slide actually. There are about, in the last 5 years, US FDA has approved 57 molecules for human use. 57 molecules. The average cost of these 57 molecules is approximately $150,000. That's the average cost of a single treatment. And the actual increment in life is 4 weeks. Mockery of medicine, unfortunately. Thank you.
Thank you, sir, for this informative talk emphasizing the integration from different streams. I would now like to thank, on behalf of Science Club Colloquium and Center for Complementary and Integrative Health, Ayush Center of Excellence, our today's speaker, Professor Gadre and Professor Kumbar, for giving us this opportunity to volunteer for the program. And we would also like to thank Pumba Auditorium and Khare sir for the videography. So, thank you.